Hi, today I'm going to talk about the use of abdominal ultrasound to help diagnose the cause of back pain in the clinical setting. So that's in our clinic, otherwise known as point of care ultrasound, POCUS. The talk was triggered off by a discussion I had with a colleague, a medical colleague, a friend who had retired, and in that way that medical people can when they talk to people like chiropractors and osteopaths, she rather disdainfully asked me, what possible use could abdominal ultrasound be to a chiropractor? So this talk is my response to her, and you'll find out how that goes. So that was her. So today I'm going to talk about why I'm interested in abdominal scanning. I'm going to talk about two indicators that we might use that might make us think that an abdominal ultrasound scan is a good idea. I'm going to talk about the benefits of abdominal ultrasound scanning on patients with back pain, and I'm going to talk about some of the pitfalls, and there are pitfalls, of course, like everything. I'm going to talk about some of the pitfalls of abdo scanning with patients with back pain. So first of all, let's talk about why I'm interested in abdominal ultrasound scanning. Well, back in 1978, my mother went to a chiropractor, a very well-known guy called Ray Broom, and he was really helpful. He found that she had some sacroiliac pain, and he treated her with some gentle chiropractic adjustments to her pelvis, and she got some relief, which was great back in the day. My father said it was the best £5 he ever spent. And it was suggested to me that perhaps I would train as a chiropractor, and I did down at ACC, and I graduated in 1986. Now, a few years later, my mother had a hysterectomy because she had fibroids. Now, could the fibroids have made her sacroiliac joint painful? Well, no one suggested it at the time, but I think it's quite possible that they did. So hang on, I maybe became a chiropractor because of my mum's gynecological history. Bit weird. Okay, a few years ago, I did my abdominal ultrasound certificate. This is one of the family guinea pigs who I'm scanning here. And it's important if you do ultrasound training that your course is CASE recognised. CASE is the Consortium for the Accreditation of Sonographic Education. So don't just do any old course, make sure your course is CASE accredited. Now I'm a chiropractor and a sonographer. This is the bladder stone that we picked up on Jill's, the guinea pig's bladder. So you can see the stone here, nice bright white reflective shape here with a big shadow underneath it. But I'm far from being an expert sonographer. I simply want to identify patients who have back pain and try and find out why they have back pain. And I would like to think of it a bit like being a detective. So there was a paper produced by Amanda Hall and colleagues back in 2021. It was kind of a nice paper from a chiropractor's perspective because chiropractic got a little bit of a look in, but I'm sure she was referring to osteopaths and physiotherapists as well. So that was kind of nice, but really it was nothing like damning with faint praise because her quote was, "Most cases of low back pain are simple strains and strains of the back that, while painful and unpleasant, improve rapidly, just like a sprained ankle." So I wasn't sure quite what to make of that really, but I don't think it made her impression of chiropractors and osteopaths perhaps terribly good. And I'm actually not sure really that I agree with that phrase at all. And it's one of these phrases that gets bandied around, non-specific low back pain. What does that mean? Well, it means you don't know what's causing the back pain from my point of view. But yeah, most back pain is seen as mechanical, but I'm not completely sure that it is. Now, in Amanda Hall's paper, she talks about this sort of process of things that should occur. So number one, patient presents to the practitioner with back pain. We then do a history and a physical examination. And then number three, and I'm not sure about this, exclude non-spinal causes of back pain, including visceral causes. So that's easy to say in a paper, but I think it's much harder to do in practice. How should we as chiropractors and osteopaths and physiotherapists do this in our practices? Well, as well as feeling the area around the back where the patient's indicating their back pain, we should always palpate the front of the patient. We should palpate the abdomen, and it's often surprising how often it's tender in the front of the abdomen, and it's very easy for the clinician to forget to do that because the patient's symptoms are at the back and the patients don't realise how tender it is. And this is our first clue about doing an abdominal ultrasound scan, is finding abdominal tenderness to palpation. I think we should also do a urine test routinely. They're very cheap to do, they're very quick to do, easy to do in the clinic. It might show some blood. Now, this might be there for all sorts of reasons, some of which may be entirely normal, like menstrual blood, but it may be indicative of problems with the bladder, the kidney, prostate problems, and gynecological problems. And this is our second clue. So, microscopic hematuria. Two indicators for doing an abdominal ultrasound. Number one, abdominal tenderness, and number two, microscopic hematuria. I have a small ultrasound unit in my consultation room. It's a Sonocyte M Turbo. It's the sort of Ford Mondeo of ultrasound scans, made for the American military. So it's nice and simple and pretty robust. Ultrasound has been described as the stethoscope of the future, and I completely agree with that. Having used ultrasound now for quite a number of years, I wouldn't want to practice without it. So we're going to have a little look inside the abdomen today. I'm going to take on a little bit of a tour, going in a sort of anti-clockwise direction around the abdomen. So first little challenge for you, get your pen and write down 2 organs in the right upper abdominal quadrant that might be tender when you give that area a poke. Okay, give yourself a pat on the back if one of the organs that you wrote down was the liver. Here's the liver. It's a large organ in the right upper abdominal quadrant, tucked up under the rib cage, and it shouldn't protrude down below the rib cage. If it does protrude down below the rib cage, then you have an enlarged liver. And one of the things that we see when we scan livers quite commonly is a fatty liver. So here's the liver. This is where we have the ultrasound probe at the top here. This is a fatty liver. So it's sometimes called hepatic steatosis. So this is fat within the liver, and the echogenicity of the liver is increased. So it becomes brighter, it becomes whiter, particularly compared to the cortex of the adjacent right kidney. Now, this is fat that's stored in the liver, and it doesn't mean necessarily that you have a fatty diet. Any calorific intake will be stored as fat in the liver. One of the causes of a fatty liver will be excessive alcohol consumption, and another very common cause of a fatty liver will be just too much calorie intake. But certain medications will also give a fatty liver, and we can also get viral infections. So you've heard of hepatitis, and viral infections can give us a fatty liver as well. So finding a fatty liver on someone's abdominal ultrasound can open up a whole area of discussion, and I find it very interesting how when we see a fatty liver, I find as a clinician it makes it much easier for me to ask the patient questions about how much they drink, how much they eat, whether they've had any viral infections, and also to review the medication that they're on. But commonly it'll open up discussions about alcohol abuse, which weren't proffered by the patient before when I asked them about their diet. We might see cysts in the liver. You can see here large liver cysts. Mostly they're not a medical worry, but they can be quite sensitive. They can make the liver a bit tender. And when we squat down, of course, we squash the liver. So if the liver is very sensitive, that can then kick off muscle spasm in the back. Here's a case of a metastasis in the liver. This patient had a renal cell carcinoma, and this is the metastasis in the liver here. I haven't seen very many metastases in the liver in my relatively short ultrasound career, but they can be quite variable in appearance, and fattiness in the liver, steatosis, can make it hard to pick those metastases up. Now, the other organ that you can give yourself a pat on the back, if you wrote it down earlier, is the gallbladder. So this can kick off tension in the quadratus lumborum, and Gallstones are something we see quite commonly on ultrasound. Here's a little collection of gallstones. Looks like it's kind of one big stone, but maybe it's a few different stones that have collected together. And this causes this characteristic shadow that we see when we scan a gallbladder with stones in it. If the gallbladder is becoming inflamed, then there'll be some thickening of the gallbladder wall, and we'll often see a little layer of fluid around the gallbladder if the gallbladder is particularly angry. And this normally means that the gallbladder really needs to be removed. But the question is, is it relevant? Loads of people have gallstones. They reckon about 80% of people that have gallstones have no idea that they've got them. So we've really got to be very wary as sonographers that if we see something, it doesn't mean that's causing the patient's problems. In the same way that, back in the old days when we used to take x-rays of the spine, just because you can see a curve in the spine doesn't mean that that's causing the patient's pain, because if you re-x-ray them after you've treated the pain and the pain's gone, you'll probably see the same curve on the x-ray. So some sonographic findings might not be relevant. So just because we can see it, it might not be relevant. This patient also has thoracolumbar muscular spasm, but they've got a compression fracture, much more likely to cause the patient's back pain in that case. Let's move a bit further round the clock face and look at the right kidney. Now, you can see as we scan the kidney here that there's a large hole in the kidney. This is an 8 centimetre cyst in the kidney. Medically, it's not a problem. Kidney function tests are all normal, no blood in the urine, but it does make the kidney quite tender when we stick our fingers in there. Would it explain the patient's recurrent ipsilateral back pain? I think possibly it would do. Now, if kidney cysts are complex, they need to be referred. If we can see septations and debris in the cyst, then they need to be referred by the GP to the renal department for evaluation, because they have a much greater likelihood of becoming malignant. And there is a classification system for this, the Bosniak classification. Essentially, if a cyst is a single cyst with just fluid in it, no septations, no debris, it doesn't go malignant, it's quite safe. But if there are cysts there with lots of septations and lots of debris in them, then they're much more likely to become malignant. So you can grade these things. But basically, when I pick them up, if I see any septations or debris, I send them off for evaluation. End of story. Now, this next patient had a little bit of blood in their urine. I scanned the patient. I could see a mass at the cranial end of the kidney. You can just make that out, I think. It was distorting the flow within the kidney. It was about 5 centimetres across. I didn't know what it was. It just didn't look right to me. So I wrote a letter to the GP and suggested this was looked at on a CT scan, and that's indeed what happened eventually. And one of the problems with doing ultrasound scans and picking up things like this is that it creates anxiety, both for the patient as well as the clinician. We think, oh my goodness, am I making this up? Am I really seeing something there? Or should I get it looked at? Am I just wasting somebody's time? It creates anxiety for the clinician, but it creates anxiety, and more importantly, for the patient as well. There's a paper that we'll have a little look at later on that tried to quantify this, and this paper reckoned about 5% of people who have a scan in a primary healthcare setting, 5% of them get very anxious about it and don't like the idea of it, but 95% of people that have a point of care ultrasound scan feel better for it and feel that their condition has been taken more seriously. The patient in question who had the CT scan turned out to have a renal cell carcinoma. So I was really lucky to detect that, because ultrasound often misses renal cell carcinomas. Ultrasound specificity is low, and this is one of the downsides of ultrasound scanning, is that you can't always rule things out. And renal cell carcinomas, as I say, are commonly missed on ultrasound. We scan a tender kidney on a patient that has some hematuria, and we think there might be a problem, but you just can't see it on ultrasound. And the fact that you can't see it on ultrasound doesn't mean that there isn't a problem. So the specificity, that's what the specificity is low. But this patient did have a renal cell carcinoma. I know I've missed at least one renal cell carcinoma in the time that I've been using ultrasound in my clinic. I suspect there may be more than that I've missed. Another condition that will cause blood in the urine, hematuria, and back pain, of course, is a kidney stone. And here it is, you can see it with the acoustic shadowing, very characteristic of a kidney stone, and this twinkling artifact that we see when we put colour Doppler onto the screen. Patients with this sort of kidney stone nearly always end up in A&E because it's agony. They're not going to the GP or to the chiropractor. These patients are hauled off to A&E, not the chiropractor. The kidney stones that come to chiropractors and osteopaths and physios, I think, are much smaller. But if they're smaller than 4 millimeters, they're not visible on ultrasound. Now, what we're looking at here may be normal anatomy of the central part of the kidney, but it might be a kidney stone. And one of the problems that we have here is that ultrasound has low sensitivity. So if a stone's less than 4 millimeters, we might not see it. So this is one of the downsides of ultrasound. The sensitivity is low. Ultrasound is really good at seeing big things that contrast significantly with the surrounding tissue. It's not very good at looking at small things that don't contrast very much with the surrounding tissue. Now, one of the problems with kidney stones, apart from causing severe pain in the kidney, is they can move down the ureter, and that can block the ureter. Remember, the ureter takes the urine from the kidney down to the bladder, and if you put a stone in there, you're going to block the flow of urine down that tube. And the problem then is that you get back pressure into the kidney. And because the because the capsule of the kidney is very tough, the kidney doesn't really expand, but the filtering structure of the kidney gets pushed to the outside of the kidney. And this is called hydronephrosis. And you can see this is a case of hydronephrosis, grade 4 hydronephrosis. And of course, the filtering structures are being squashed like this are becoming damaged. So hydronephrosis is not good for your kidney. This patient's hydronephrosis was caused by something else, a problem low down, down in the uterus. This patient's got a fibroid and is probably compressing the ureter. Remember, here's an X-ray with some contrast material in it. So here are the kidneys. Here's the contrast material in the ureters going down into the bladder. Now, if you stick something on the ureter and squash it, like someone standing on a hose, you're going to get a problem with back pressure back into the kidney. Here's a fibroid that's squashing the bladder, making the bladder much smaller. This creates urinary frequency, and so the patient will be complaining about needing to go to the loo all the time. They might think that they have a urinary infection, but when we do a urine test and we're looking for nitrite, we might not see that because they may not have an infection. They may simply have a smaller bladder because it's being squashed by a fibroid. These patients often get back pain at night because the weight of the fibroid makes the uterus move more, and when the patient turns over in bed, it's really uncomfortable. So it's really worth, as chiropractors and osteopaths and physios, us quizzing patients about nighttime back pain and whether it's related to moving in bed at night. And it's also really worth asking how many times a patient gets up at night to have a wee, because if they're getting up quite a few times during the night, then there may be something that's making the bladder effectively smaller. Okay, so fibroids feel like a lump when we palpate the abdomen. You can feel it's a muscular thing. If you know that fibroids are muscular growths within the benign muscular growths within the uterus, and they're very palpable. But that contrasts with ovarian cysts. So ovarian cysts will tend to be either in the right or the left lower quadrants. And when you palpate there and the patient's tender, but you don't feel anything hard, it may be because there's a fluid-filled cyst. So if you imagine a balloon filled with water and you're squashing it, it's quite squishy, and so you can't necessarily feel that under your fingertips when you're palpating the patient's abdomen, but a fibroid is much more obvious to palpate. So here's a 75-year-old lady who had tenderness in the right lower abdominal quadrant. She had come to me with right-sided back pain. Her sacroiliac was painful, but because she was tender in the right lower quadrant, I scanned her. She had a 5-centimeter ovarian cyst. This 83-year-old lady had a bigger ovarian cyst, a 7.5-centimeter ovarian cyst. Again, tenderness in the right lower quadrant, right in front of the ipsilateral sacroiliac joint. Both of those patients went on to have surgery, and there are a variety of opinions about this, but essentially cyst size and complexity are the issues. But they both had surgery, and it was very successful, and helped their back pain. Okay, so this is an older man who had left-sided back pain, so he's grumbling to his wife about his back pain. He came to see me, and I scanned him because he was quite tender in the left flank, and when I pressed the ultrasound probe against his kidney, it was pretty tender. So this is called a positive sonographic Murphy sign. But the kidney largely looked okay. A year later, though, it looked different. So he was starting to develop hydronephrosis, and the flow of urine into his bladder had altered. So we can see here the right ureteric jet. So if you remember, urine is pulsed down the ureters into the bladder, and when you look at it on ultrasound, it's like a flare, the gas flare on an oil well, and it happens for a couple of seconds and goes away, and then you might well see one on the other side, and it kind of alternates ish. So we want to see two ureteric jets visible on ultrasound. So here we can see the right one, but we can't see one on the left. It wasn't visible. So the implication is that there's some compromise of flow of urine down his left ureter, and an enlarged prostate can cause hydronephrosis and cause a patient to have back pain. What we can't tell when we scan someone's prostate, and we can look at the prostate through the bladder, we can look at the prostate and measure it, so we can take measurements in 3 different dimensions and do a volume calculation. Anything over 30 millilitres in volume is deemed to be enlarged on ultrasound, but ultrasound won't tell us whether an enlarged prostate is cancerous or just simply enlarged benignly. We can't answer that question. Okay, let's move up to the left upper quadrant, and again, get your pen out and just write down an organ that might be tender if you poke into the left upper quadrant. I'll give you 2 seconds to do that now, and of course you've written down the spleen. Now, basically with the spleen, essentially, if the spleen is a normal size, we don't worry about it. So anything below 13 centimetres, that's fine, we don't worry about it. But if it's above 13 centimetres or 13.5 centimetres, then we start to think, the spleen may be enlarged. And there are basically 2 categories of reasons why this will happen. One is that if there's a problem within the spleen itself, so some of the lymphomas and so on, the white blood cell cancers can have their roots in the spleen here. But also if there's a blockage further down the line where the spleen drains to, so into the liver, it goes down the splenic vein just near the pancreas and goes down towards the liver that way. But if something's blocking it, then you get back pressure, and that will make the spleen bigger. Now, you can see this patient's spleen, 19 centimetres, so it's enlarged. And this patient actually turned out to have cirrhosis of the liver, and that was limiting blood flow from the spleen. Okay, so moving down a little bit from the clock face into the middle of the clock, let's talk about aortic aneurysms. Normally occur in older male smokers or ex-smokers, but can occur in women and can occur in patients who aren't necessarily smokers. One thing, incidentally, they're more common in patients that are hypermobile, and they're more common in patients with autoimmune inflammatory joint disorders like psoriatic arthritis. So any patient that I see who comes in with back pain that I'm suspecting has psoriatic arthritis, I tend to do an ultrasound scan of their aorta to make sure that they haven't got an aneurysm. Now, essentially with the aneurysm, we're doing a cross-sectional measurement of the aorta here and seeing how large it is, and if it's above 3 centimetres, then really the hospital is interested in monitoring it. They won't do anything at 3 centimetres. They'll tend to start to get interested in doing surgery when the aneurysm gets to 4.5 centimetres or more. But more than 3 centimetres, the hospital will want to have a look at them. Anything less than 3 centimetres, the hospital isn't interested. But what I tend to do when I see an aneurysm there that's it's still an aneurysm but less than 3 centimetres, I do write to the doctor anyway and say that I've picked up this aneurysm and that might influence their decisions about the patient's blood pressure and the patient's cholesterol, because patients with high blood pressure and patients who have high cholesterol levels are more likely to have their aneurysm progress. So the GP might like to manage those 2 things a little bit more aggressively. This patient's aneurysm is 4 centimetres, so this would be referred. Do aneurysms cause back pain? Well, that's very difficult to answer. There are quite a few authors that state very categorically that they don't cause back pain, but there is lots of literature where authors are talking about conditions of back pain, and these patients have aneurysms. And I think aneurysms can cause back pain. I think the bigger the aneurysm is, the more likely it is to cause back pain. And I think that aneurysms of the iliac arteries are particularly likely to cause back pain because the iliac arteries traverse right anterior to the sacroiliac joint. So if I see a sacroiliac joint that's sore and I'm scanning a patient, I'll be particularly keen to look at the iliac artery right in front of the sacroiliac. Back in the old days when we used X-rays, we used to see them incidentally on an X-ray, and you can see that aneurysm there. Patients just want us to treat their back anyway. It's funny, but I'm happy to treat a patient that has an aneurysm as long as it's not too large. But once it starts to get like 4 centimeters, I'm not sure that I really want to be squeezing the patient and pushing them around. I think maybe it's not such a great idea, but I've got no evidence to base that on, really. So guess how many aortic or abdominal aortic aneurysms I saw last year. I used to think that we didn't see many aneurysms in practice because, back in the old days when we x-rayed, we just occasionally pick up a calcified one, but we wouldn't pick up the others. I saw 8 aneurysms in the last 12 months. Now that sounds, I think that's quite a big figure, but to put it in context, only one of them needed surgery. Most of them didn't. They were just being monitored. Okay, so let's move up to the top of the clock face and look at the pancreas. Now, the pancreas is a very difficult organ to visualize on ultrasound because its echogenicity is very similar to that of the tissues that surround it. So it's one of those things that, I think we say it's normal at our peril. So this is the pancreas coming around here. Most problems, so pancreatic cancers, most of them will be in the head of the pancreas here. But you do sometimes see problems in the tail of the pancreas. And this is the splenic vein coming around here. You need a lot of experience really to comment on the pancreas with confidence. Slim people, they're much easier to their pancreases are much easier to scan. This is one of the downsides of ultrasound. If we're not experienced at looking at the pancreas, then it's really hard to comment with any kind of confidence. Okay, so this all sounds good. Why isn't everyone doing it? Well, there are downsides about that. And I'm going to use this paper published by Camilla Anderson back in 2019 in the Annals of Family Medicine. It was looking at using ultrasound at the point of care in general practice. So not chiropractic practice, but general practice. And these were the things that she came up with, which is, and I agree with nearly all of what Anderson said in her paper. And it's a paper that's really worth reading if you're interested in doing abdominal ultrasound scanning at the point of care. So let's talk first of all about relevance. So I touched on that earlier with gallstones. Just because we can see gallstones as chiropractors, does it mean that's causing the patient's back pain? Well, it might do, but it might not do. And that's something that we have to use our clinical judgment to decide about. Sensitivity. So sensitivity is a problem. Ultrasound is great at looking at big things. Those big liver cysts, they were easy to see, weren't they? That big 8 centimeter kidney cyst, that was easy to see. 3 centimeter, 4 centimeter, 3 millimeter, 4 millimeter kidney stone, not so easy. So sensitivity is a problem. Specificity is a problem. We can't always rule things out. We can't say, no, there isn't one. So with the kidney, what I'm particularly interested in is renal cell carcinomas. Just because I can't see it, does it mean it's not there? No, it doesn't. It's easy to miss them, and I have done. We make patients anxious when we do these procedures, but we also make patients anxious when we take their blood pressure. And you've had plenty of patients, I'm sure, where you've done their blood pressure and their blood pressure's high. Patient goes running off to the GP, freaking out, in spite of you saying that it's just white coat syndrome. Look, we'll just do it at home. Don't worry about it. Some patients just get anxious, whatever you do to them. And that's certainly true of abdominal ultrasound scanning. I don't think it is a good reason not to do it if we've got those 2 reasons ticked to do it. We'll go back to those in a minute. Experience. You need experience. Like taking x-rays. If you take, 2 x-rays a year, you're going to be rubbish at taking x-rays. If you do 2 abdominal ultrasounds a year, you're going to be rubbish at doing abdominal ultrasound scans. In Anderson's study, the GPs were doing anywhere between 150 and 600 ultrasound scans in a year. I was doing about 300. I would say per year. You do need good training, so when you do your training course, you need to make sure that you do a course that's case certified, and of course you need to do ongoing training and revalidation and make sure that you get people looking at your technique and giving feedback and commenting on the scans that you're taking. Now, one of the things that Camilla Anderson did not talk about, because her study was looking at GPs, so medical professionals, what she didn't talk about was interprofessional stress. And this has been a much bigger issue than I thought it would, because when I started scanning, I thought it would be great. GPs would think it would be really helpful if I picked up abdominal pathologies. They'd be thinking, oh, great, he knows what he's talking about. Fantastic, we'll send all our patients to him. But it's absolutely not the case at all. GPs complained to me about increasing their workload. They said I was stressing their patients. They wanted to decide when a patient had an ultrasound scan, and they queried my qualifications. What would I know about ultrasound anyway? You're probably not properly trained. You're just a chiropractor. Do some manipulation. That's what chiropractors are supposed to do. And for many years, I had a steady stream of GP referrals, and felt rather proud of myself for that. And then since I started to do abdominal ultrasound, my stream of GP referrals dried up and went to zero. So if you want to kill your GP referral practice, start doing abdominal ultrasound scanning. I think the relationship between the medical doctors and the chiropractors or osteopaths or physios and the patients is a complex one, and we have to decide, who are we working for, who are we trying to help, and I think the only thing that actually matters, in my opinion, is the patient. A lot of the issues that that I've mentioned just now about GPs' objections, I think are based on professional jealousy. GPs currently don't use ultrasound in their practices, but I am absolutely convinced that the next generation of GPs will be using ultrasound in their practices. They will have a quick look at things like we do with stethoscopes to have a listen. They'll use their little butterfly ultrasounds, attached to their iPhones, and they'll have a look at things. And we're really being left behind massively, because what will happen is that if you're not in the club, you'll be ruled out of the club. I think if it helps us to understand why patients get their pain, I think it's a good tool. I think it's really interesting. I think it's really helpful. And it's really worth us thinking about what is our role as a practitioner. Are we working just as technicians to correct subluxations or get rid of fixations, or to improve spinal mobility, or to improve core stability, that favourite thing of physiotherapists? Or do we see our roles as something more than that, something more interesting, more interested, like a detective? I think you know which camp I would put myself in. Right, okay, let's bring this thing to a little bit of a close. So I talked a little bit about why I'm interested in abdominal scanning, and it started off with my mother having a hysterectomy all those years ago, and this question mark about whether there was something gynecological that caused her back pain, in spite of her being helped hugely by the chiropractor that she saw. I went on to talk about 2 indicators that might make us think about doing abdominal ultrasound. Let's see if you can remember them. Number 1, a tender area in the abdomen when we palpate it. Number 2 was some blood in the urine when we do a urine test, microscopic hematuria. Okay, the benefits of ultrasound. I think the main benefit is that it helps me to have a greater understanding of what might be causing the patient's pain. Although it's a very medical procedure, I think it makes me look at the patient in a much more holistic way. It might make me have a much better discussion with the patient about alcohol use, about eating, and so on. And it makes me also quiz the patient much more about their bladder function, their bowel function, and also it saves some lives. There are a couple of patients I know that by picking up pathologies, it has saved their life. So it can be life-saving, but there are pitfalls, and Camilla Anderson's paper highlighted those. the lack of sensitivity, the lack of specificity, the training required, the anxiety that it can create, and the interprofessional stress that it can create, certainly between my practice and the GPs around me. There are pitfalls. So, you can't go into this and think it's all going to be sweetness and light and nice and easy and simple and everyone's going to love you. That's what I thought. But it was difficult. It has been a difficult journey. I think it's been fascinating. I've been very happy that I've done it in spite of ruffling some medical feathers. I don't think that's a problem. I think ruffling a few feathers is sometimes helpful. And sometimes we have to do things that are difficult because they're worthwhile and that it's in the best interest of the patient. At the end of the day, it's the patient that matters. So this was the sort of blurb I said to my retired consultant friend, who said, what possible use could abdominal ultrasound be to a chiropractor? And I think she understood it once I'd spelt it out like I have done today. So many thanks to the 1,500 or so patients who've let me ultrasound scan them. I'm really, really grateful to them for being my guinea pigs, and thank you for watching. There are a few references here which I'm sure the good folks at APM will send out to you if you want, and this is how you can get hold of me if you want to contact me. Thanks for watching. Bye for now.